Ladies and gentlemen, the format of today's conference is a little different than some that you have been used to. The intention here was to try to provide you with some new information, with new hot stuff. And therefore, we have a number of people who are speaking and who asked to speak, so that we would be able to present new information. So this is not the kind of conference where you're going to have an opportunity for a lot of questions and a lot of slow dialogue. We are going to do it a little differently this time. We hope that you will like this format. At lunchtime, you can talk to each other and talk to the speakers, but we're going to have to move very quickly, bang on. I would like to divert for a moment from the program. You saw at the beginning, the welcome and opening remarks, there were 3 names. And we decided very quickly that it made more sense to change that order a little bit. And so now as we move from the UK into a more international perspective, I would like to introduce to you Ariella Lowenstein, who is the regional representative for Europe. And she's going to make a few brief remarks now, and she will be speaking again later on.
Thank you, Gloria, and it's heartwarming to see all this crowd here. It's actually the second time that World Elder Abuse Awareness Day is in Europe, and I think it's so appropriate that this time it is in the UK, because actually almost more than 3 decades ago, the beginnings of work on elder abuse started both in, as far as Europe, first in the UK and in North America. And I think we made really quite important strides forward. We have lots of data, we have lots of intervention, but I think we still have many challenges ahead of us. And as was mentioned in the morning, we have to look more deeply into our conceptual basis when we make both our prevalence studies and other type of research, because our conceptual base was very much ingrained in work against abuse against children or abuse against women. And now I think the time is ripe to have it more specifically for elder abuse. We also have to develop more evaluation method to look at our interventions, to look at our service provision, etc., which I think we don't have enough. And it's wonderful that we are celebrating World Elder Abuse around the globe, which was supposed to be yesterday in all the countries, even though in some specific countries the date might shift within this month, but that's fine. So welcome all of you. We have a very intensive and challenging program ahead of us, and I wish you all fruitful deliberations.
Our next speaker is Jutta Linder, who is going to be speaking remotely from Germany. Her son is graduating from university today, and the flights were impossible to arrange so that she could get back to Germany in time for the convocation, which is at 3 o'clock this afternoon. So we have her on the line. We hope. But Jutta is professor of public health at the Protestant University in Ludwigsburg, and a visiting scientist at the University of Leipzig. And her research interests focus on mental health, on the health impact of violence and life events. And she's also investigating factors which influence aging, amongst other historical events, and genetic and environmental factors. And she is the principal investigator of a major piece of research looking at the prevalence of elder abuse. Now, she was the one that was trying to get through to us before. But just to put things into perspective a bit, it was very interesting when Gary was giving you the statistics, and where we've got a number of studies where the estimates, prevalence rates, seem to be ranging between about 4 and 8%. To put it in context, remember that when we talk about Alzheimer's disease, that's 6% of the population. So this means that elder abuse is at least on par with Alzheimer's disease in terms of prevalence, which is not something that most people realize.
Gloria? Hello?
You need to speak to her from here.
Yes. We can see you, Jutta, loud and clear. You can. I don't know if you can see us, but we have over 100 people here in the room, and we're very interested to hear you talk. And I explained that your son is graduating today. So.
Yeah, I'm so sorry. Thank you very much, Gloria. I would love to be with you, but these are family obligations, and I have to be there. So sorry for not being with you today.
Okay.
Should I start? Can
Yes.
you hear me?
Yes, please start.
Okay, excellent. I tried to share some slides with you, but apparently we have to learn the modern technology. So I will talk today about the results from our study, and I call it in the twilight zone because the prevalence of abuse still, there are a lot of dark spots. And this is a study done with the principal investigator from Sweden, Joachim Soares, and 6 other countries involved. First of all, I will say something about the background, then about the world study, the aims, methods, and results. The world study was funded by the Transcodes, by the European Commission, and thirdly, I will conclude by telling something about the public health agenda, which could evolve from these results. We know that the studies on abuse of old people are the last in the historical development of studies on abuse. First came the studies on violence and health of children, then studies on violence and health of women, and finally the studies on violence, abuse against older persons, evolving from Canada, from the UK, from Samuel Wicks, probably he will be there, with you from Israel, and now our study is one of the first studies comparing prevalence rates and associated factors in 7 European countries. We have up to now a variety of prevalence rates of abuse, and there might be some methodological reasons for that and some content reasons. First of all, if we look at the methods, there we have a variety of definitions and a variety of forms of abuse included. The age range of the population varies We have included people from 60 to 84, but of course there could be other age ranges possible. The inclusion and exclusion criteria of the population needs to be defined and might vary. The types of prevalence included. Do we speak about the past month prevalence or about the past 12 months prevalence, about lifetime prevalence? This gives different numbers. And of course, last but not least, the validity of the instruments, which often are not validated in older population samples. This is as regards the method, but there might be other reasons for the variety of prevalence rates as well. For example, differences in gender roles in different countries, differences in age roles, differences in the awareness of abuse, or differences in response behavior, depending on age and gender. So first of all, until there is some discussion to be done, we need a definition what is meant by abuse. And I refer to the UK definition, and we referred in our study on this definition as well, that elder abuse is a single act in a relationship where there is an expectation of trust. And this might be one of the very interesting things if we discuss the data. So we included psychological abuse, physical abuse, sexual, financial abuse, and neglect. We intended to describe the lifetime and the past 12 months prevalence rates of abuse, and to describe and analyze the factors associated with this abuse. It is a cross-sectional, community-based study with clear inclusion and exclusion criteria, so we included only the individuals living in the community, not the individuals living in care settings, and not individuals living in residential care. Perhaps then it would have other reasons. And we excluded people with cognitive impairments and with dementia. Our instruments were, first of all, a standardized socio-demographic and socio-economic instruments, then the widely used hospital anxiety and succession scale, measures of social support, and for measuring the depending variable abuse, a violence questionnaire with 52 items based on the conflict tactic scale. For the analysis, first of all, we described the variables, we made multivariate regression analysis, multi-level analysis, and now we are doing the cluster analysis. If we look at the results, we had about 4,467 participants, 57% women, and the mean response rate was about 50%. It is perhaps low, but in some countries the response rates in this moment are between 20 to 30%. Our age range was 60 to 84 years, with a mean of 70 years. Most of these people were married and had their education between 5 to 11 years. Now we come to the prevalence rate of any kind of abuse. And we found, interestingly enough, a pattern of northern countries and a pattern of southern countries. The highest abuse rates we found were in Sweden, Germany, and Lithuania, with about 30% of any kind of abuse, and the lowest rates in Spain, Italy, Greece, and Portugal. If we look in detail to the different types of abuse, we can see more country-specific differences. Psychological abuse seems to be highest in the northern countries. Sexual abuse is quite low in all countries, with the highest rate, but still very low, in Greece and in Portugal of about 2%. And financial abuse comes up to 4 to 5% in the southern countries, in Greece, Spain, and Portugal. So we can see a quite detailed picture with differences between countries. If we look at the factors associated with abuse, we have to differentiate the different types of abuse. Factors associated with psychological abuse are age, so the younger age groups report more psychological abuse, financial strain, and as an indicator for socioeconomic status, ownership of homes, people who owned property had reported lower rates of psychological abuse than people who didn't own a property. As regards physical abuse, we see a relationship between occupational level and again financial strain and physical abuse. If we look at financial abuse, we see that men report higher rates of financial abuse than women. This might be related to the financial status men still have in Europe. Sexual abuse is associated with females and with the living situation of living alone. So if we look at the overall picture, we can see that factors which are associated with all kinds of abuse are age, financial strain, ownership of property, on the one hand side, and on the other hand, social support, which gives a kind of protective factor, but nevertheless it's a very small effect. The main perpetrators of violence were partners. Remember that the prevalence rate of psychological violence in our family at least was quite high. So main perpetrators were partners, followed by children, physical violence and psychological abuse and physical abuse. We can see this in bivariate and in the full adjusted model, and this is quite interesting. So let me summarize. The prevalence rate varies very much in Europe. The most frequent abusers are family members, the intimate partners or the adult offspring. Factors associated with abuse are individual factors like age and gender and ownership of property, relationship factors, living in a partnership, and country. The main factor seems to be from which country a person comes. Now I come to conclude to the public health agenda. What do we need? I think coming from this result, we really need more interdisciplinary cooperation of the diverse disciplines involved in research on abuse. For example, epidemiologists, gerontologists, medical doctors, nurses, psychologists, public health scientists, and social workers to get the real picture of abuse, and we need to improve the methods of research and perhaps to critically analyze whether abuse might be a topic of criminologists or might be not a topic of criminologists if we see that it's mainly associated with partnerships. So we need the development of efficient intervention and prevention strategies based on these robust data, and of course the evaluation of these strategies. So let me thank to the many people who were involved in the WELL studies, above all the older persons who took the time to answer our sometimes distressing list of questions. And of course, thanks to our members of the WELL Research Group, and thank you to you for listening.
Thank you very much, and I hope that you will send me your PowerPoint and we will make it available to the people that are here.
Yes, it will be a pleasure.
Okay. Thank you very much, and goodbye.
Goodbye. It's a nice conference.
I think this, we wanted to introduce this study to you because it makes very clear the issue that you will find differences between the different countries, but also that prevalence rates and risk factors vary depending on which type of abuse or neglect you're talking about. There is not one size fits all when it comes to looking at risk factors, and I think that's part of what has held the field back. We also wanted to introduce this study and the next 2 or 3 that we will be talking about today, because to answer Mary's question, I think there have been some major advances in the type of research and in the sophistication of the research that is going on, and I hope you will agree as the day progresses. I'd next like to call on Bridget Penhale, who's going to talk about one of the other very important studies. And you do have the biographies of all the people, so we will not go into a lengthy introduction.
Thank you, Gloria. Good morning, everybody, and thank you all for being here this morning. Before I start with my presentation, I would just like to make a comment in response to an earlier question which was put to Gary Fitzgerald about the reason for research participants in the UK prevalence study being 66. The main reason for that decision was that there was a decision to look at 12-month prevalence. So they wanted to look at prevalence over 12 months since the person turned 65. So what that means is that respondents had to be 66 in order to talk about what had happened to them since they were 65. So I just wanted to clarify that. I'd like to very quickly try and run through a study that I've recently been involved in with colleagues from a number of different countries. You will see acknowledgements that I'm making to the German Police University and NGO Zoom Perspective, the Institute for Conflict Research in Vienna, Institute of Sociology in Budapest, Hungary, the University of Białystok in Poland, and an NGO called CESIS in Portugal. We received funding for the study from the European Commission within the Daphne 3 programme. Daphne is a programme which supports research on violence against women and children, and this particular piece of research was on intimate partner violence and older women in 6 different European countries. And obviously, when I'm making my acknowledgements, what I need to do as well is to thank the older women and the professionals who participated in the study, without whom it wouldn't have taken place. The Daphne programme, as I've said, has a focus on violence against women and children, and in the third iteration of the programme, running between 2008 and 2013, there was a special focus given to older women. That meant that 3 projects have been funded within the frame of that study. The AVOW study, Abuse and Violence Against Older Women, which you will hear about this afternoon. The Eustacia project, which stands for EU Standards and Charter on Elder Abuse, which wasn't specifically about older women, but served to create a Charter of Rights, and the Intimate Partner Violence and Older Women study that I will tell you about. Intimate partner violence is a serious problem. We find it in all countries, we find it affecting all classes and cultures. But so far, comparatively little attention has been given to older women. Domestic violence services have really quite a limited focus on older women and would acknowledge that this is the case, whilst services in relation to adult safeguarding, or more particularly elder abuse services, seem to focus on vulnerability and care, and they tend to neglect the gender-specific issues. We took a decision within our group to explore the experiences of older women who were experiencing or had experienced intimate partner violence in old age. And what we wanted to do throughout that study was not to undertake a prevalence study, but to really try and get to the experiences and the situations of the women involved. So we undertook our study through from 2008 to the end of 2010, and we were really trying to obtain more understanding of the help-seeking behaviours of women, their support needs, and the barriers that they might have in seeking help. We used a multiple method study and in multiple phases. Just to run quickly through the phases, we collected available data in each country, predominantly from national data sources. We undertook a survey of organisations, of service providers, who might be in contact with older women who are experiencing intimate partner violence. And we also, in conjunction with that, undertook interviews with professionals. In most countries, the interviews with professionals seem to focus on interviews with social services staff from domestic violence agencies and other NGOs and from police departments. We also, in each country, interviewed a small number of older women. And then the final phase of the study was to develop recommendations, so to discuss our findings at both national and international levels and to draw up a set of recommendations. And what I'm going to be trying to give you a whistle-stop tour of this morning is the UK phase. What we found when looking for national data sources was that there were very few explicit sources and there was limited data available covering the period that we were concerned with, which was 2006 through to 2008. There were a certain number of research papers. We obtained some information from the British Crime Survey and police data, and a small amount of statistics from service providers, mainly organisations for older people and domestic violence agencies. But if I move to looking at limitations, there was some difficulties we faced, obviously, in relation to the comparability of data in terms of the terminology used, in the reliability of data, and the cut-off point for domestic violence statistics. For example, the self-completion module of for the British Crime Survey on domestic violence actually ceases at 59 years. Don't ask me why that should be the case. I've discussed it with them many times, and at the moment they're saying it will remain at 59 years. There seems to be a fair amount of underreporting as well. Police data seems to be predominantly concerned with violent crimes, while service data represents only those who've been able to engage with a particular service. And in terms of self-reports from older women themselves, clearly there are maybe a number of internal barriers in terms of shame or fear of reprisal or what might happen further. Our survey of service providers in the UK consisted of some service evaluation questionnaires in order to try and establish the extent of case knowledge. The survey was sent out between September and October of 2009, and reminders were subsequently sent. We got a very low response rate to our survey, and I think there are a number of reasons for that. Clearly, in terms of the fact that this was a European level study, there was a lot of discussion about the length and acceptability of surveys in certain countries. And we had a great deal of discussion about the number of questions that we should ask people and the extent of the questions, and a certain amount of disagreement, I have to say. The questionnaire, in my view, was far too long. Some of the feedback we got from non-respondents in the UK was that that was indeed the case. Busy practitioners don't have time to fill in a questionnaire of more than about 10 pages, and this was verging on 20. Just by way of comparison, however, the Abuel study questionnaire was 40 pages long, so they vary tremendously. The time period involved was also tricky for many organisations because they let us know that they were undergoing reorganisations or there were particular priorities at that particular time. And we were also faced with a situation where there was a lack of routine data collection. I know that subsequently, of course, the abuse of vulnerable adults data set has come into play, and that was introduced by the Department of Health last year, but for the period we were covering, that didn't exist. We got responses, however, from a range of different organisations, from a small amount of information and data from the police service, also from social services and from domestic violence agencies and from other NGOs working with older people. Our interviews with professionals were more successful. We managed to undertake 35 in-depth interviews across the range. Some of those were indeed respondents to our survey, and one of the questions was to ask people if they would be willing to be interviewed. But from discussion with individuals who weren't completing the survey, a number also told us that they would be happy to take part in an interview. So we managed to get a range of interviews from 21 different areas across the UK, including 2 national organisations, and we managed to reach staff in social services within safeguarding and social work practitioners, care management practitioners, from Women's Aid and other domestic violence organisations, and from voluntary organisations such as Action on Elder Abuse, from the housing sector, victim support. The themes from the interviews I don't have time to go into today because I want to focus a little more fully on the views and responses from older women, but the different areas that people were telling us about were the impacts of the violence, their perceived support needs of the older women, the barriers that they thought led to older women not seeking help, and challenges for services in trying to provide help in this area. The interviews with older women, in each country we aim to interview 10 older women. In fact, in 2 of the countries, they fell just short of that number, so that instead of our sample of a potential number of 60 older women across the 6 countries, we actually ended up with 57. Those interviews were not aimed to be representative. What we really wanted to do was to gain the perspectives of older women about their situations, about the help-seeking behaviours they employed, what helped or hindered them in their journeys through these situations, and where they had left those situations, what helped them to leave those situations, their ideas about service development and their potential needs. We weren't actively seeking to gain information about women's experiences of violence in older age, but of course most of our respondents actually talked about their situations in some depth. We initially wanted to gain access to women through service providers and faced some difficulties in doing that. I think some of the reason for that is that few older women engage with services, and what we were told by practitioners and staff was that they were unable to contact women for resource issues. And I can answer questions on that at some point if necessary. Women may also not be ready at a particular time to share their experiences. We attempted also to make direct contact with women through use of leaflets, articles in a local newspaper in the Yorkshire region, but we got a low response rate to that. We did, however, in the UK manage to achieve our sample of 10 older women. And the sorts of themes that came out were about experiencing life with violence, the impacts of violence on how to leave the relationship and the difficulties in that, and their help-seeking experiences. I'm going to run very quickly through these because I'm running short of time. All types of abuse, including severe physical violence and sexual abuse, were given in the reports by the older women, although not all of them had experienced all types of abuse. For many, the start of the violence had been very early on in their relationship, and there have been gradual increases and changes in their situations with life events. Their perpetrators, their partners, were described generally as controlling and jealous, as being very clever and playing mind games, and being in complete financial control of these women's situations. In terms of the impacts of the violence, the women talked about physical violence, experiences of being attempted suffocation, broken bones, emotionally losing confidence, having suicidal thoughts and post-traumatic stress disorder, of social impacts in terms of strained relationships with other family members, of feeling in a Jekyll and Hyde situation, or having to leave employment. In terms of impacts on children, those who had witnessed the abuse were described as having a multiplicity of difficulties. Some were described as being themselves heavy-handed in parenting when they came to parent. And there was a question mark of future relationships between those children and their adult parents. Of the 10 women interviewed, 8 had left their partners. In terms of advantages of leaving, the women talked about obtaining peace of mind, no longer living in fear, and of improved relationships with children, although that didn't always happen. However, there were difficulties that they experienced in attempting to leave or after leaving. There were financial implications, loss of the family home, increased strain between certain family members, and periods of loneliness. There were also increases in the violence experienced, or the partner found other ways to control the situation, particularly whilst the woman was trying to leave the situation. 2 women interviewed were still in their relationships. Their reasons for staying were varied. One of them, at least, her situation had changed, and that the violence she was experiencing had changed in character, and she felt safer than previously. Another had decided she wanted to stay in the family home, and both talked about maintaining financial security. Disadvantages of staying were the fact that the relationship might still be very unhappy and of some resentment. Most often, the women spoke with their family and friends. There was some reluctance to seek help from support services. I'm from the old school where you don't say anything, you keep quiet. You don't tell people what's happening to you. Police were only involved when a serious incident occurred. Positives from help seeking: support from domestic violence services was described as invaluable in terms of meeting other people, in terms of identifying and dealing with abuse. There were difficulties in not being offered support at the right times, in having to retell stories to different individuals, lack of options for accommodation, and gaining financial experience. The needs of older women, they talked about overall about the need for continuity of support, the need for appropriate accommodation, the need for practical support, and more information about the types of support available. A number also talked about the need for early intervention and work to take place in informing people about domestic violence from early on, perhaps, for example, in schools. Our final phase consisted of a national network meeting to discuss our findings and our recommendations and to refine them. And as I said, there was also an international expert recommendation workshop. Recommendations have emerged from our study and the consultation process and really covered 3 broad areas: future research and data collection, service provision, government and societal. I haven't time to focus on those, but just to give you a flavour of the government and societal recommendations, resources was a feature that we thought needs to be attended to in terms of accommodation, in terms of staff, in terms of rejigging services so they're appropriate for older women. There needs to be a development of policies and guidance outlining organisational responsibilities and roles in this area. The mantra seems to be awareness raising, awareness raising, awareness raising for the general public, for older women, and for professionals. There's some ongoing dissemination taking place. I'm delighted to be able to say that we've also got some follow-on funding, a new project which is giving specific attention to police and social care organisations, to develop guidance manuals, to look at templates for training and public relations and awareness raising material. Thank you for listening. Thank you for your interest in this topic. Thank you for joining us to celebrate World Elder Abuse Awareness Day. Together we are strong.
We have time for one question.
Bridget, you mentioned about this study being a UK perspective. So far, I haven't heard anything being mentioned about ethnic minorities. Is it that they are not abused?
No.
They are not abused? But I'm really disappointed because so far I haven't heard a word about ethnic minority. I work with ethnic minority. I've got a project on elder abuse and awareness, and I get these cases all the time, older women, young women, whoever. But why nobody takes it seriously? I'm really disappointed. I feel very, very upset about this.
Thank you for your comment, which of course is an extremely valid point. Within our sample, we did manage to interview one woman who didn't have an English background. We did attempt, through contacts with a number of different agencies, to see if it was possible to interview an older woman from an ethnic minority background, and unfortunately none of those agencies were able to assist us. It's not that we didn't wish to. Professionals in their discussions with us from the interviews were talking to us about the fact that this is a situation which can affect any older woman, and indeed may endure over many years. So it is not that we deliberately set out to exclude them, but I think in the time frame we had, we didn't have sufficient measures to be able to positively sample and to try and include them. Thank you.
Yes, there are some people in this room who have done some work on ethnic elder abuse, and I can tell you that there are studies going on in Canada. So it is an area that has been recognized and where there is a need for more both research and interventions, and perhaps this might be a topic that we will target for next year's seminar or conference. At this time, I'm very pleased to introduce our keynote speaker, who is going to be someone different than who you have on your program. Yesterday afternoon, I was informed that George Pinto Antunes was not able to be with us, but we do have instead with us Marek Havarda from Prague. And he has a PhD in sociology and degrees in economics and public policy from the Charles University of Prague, from Johns Hopkins University, and from the Warwick Business School. He has been with the European Commission for 2.5 years, and before that he was involved in with the NGO sector and in think tanks in Prague, Czech Republic. So join me please in welcoming Marek.
Thank you very much, Gloria, for introducing me. Thank you very much for inviting the European Commission. I have to apologize, George Pinto was not able to come. And I just learned yesterday around lunchtime that if there is an opportunity that I could come and talk to you today. So I said yes. Will you help me with the presentation? And George said yes. And then we had our secretariat to organize everything and to have a Eurostar ticket issued before I left the office. So it's quite in a rush. I had to get up quite early today, so please have patience with me, bear with me. If I'm not able to find the words and if I'm not able to express everything as might be needed. And I have to go back quite soon as well, to be back in Brussels in the afternoon, because there is a Czech street party, which is a big event in Brussels. It's very famous, and I'm meeting lots of friends there, so I cannot miss that. Having said that, I think the issue discussing today is of crucial importance, obviously, and as well, we think that research is of the key importance even more. We need to develop a good evidence in order to inform the good decision makers, in terms of help them to design better systems, services, and devices, as Lucy said, which would help us to prevent, and in case the abuse does happen, to tackle and help to solve it. And I think this is quite a good link with the topic I'm going to talk about, which is the European Innovation Partnership on Active and Healthy Aging. It's a very new initiative of the European Commission, and we hope it will help to raise the awareness of the issue, and it will as well help to put research and policy development more together and help the member states to tackle the demographic challenge Europe has been facing. I'm part of the team which is working on the European Innovation Partnership on active and healthy aging, as well as George is, so we're coming from the same floor in the European Commission. It's important to mention that there are other Director General's DGs, which are kind of departments involved in the exercise. So we're trying to cross the silos in the different approaches. So there is a DG Information Society heavily involved, and as well DG Research and Development. And of course we cooperate with DG Employment, who is responsible, as you know, for the Year of Active Aging, which is 2012, so the year coming. I would like to give you background on the Innovation Partnership and background why the issue is so important. A little bit about the content and how the works are developing, and I have to say the partnership is developing right now these days. We had a workshop day before yesterday of one of the working groups, and I will mention this in more detail later on, and we have 2 workshops next week, so it's really in making right now. And then with the last slide I will give you kind of a schedule, what are the next steps of the partnership, and if you're interested, you of course more than welcome to contact me, and I will put you in contact with potentially other colleagues who might be working on different areas, as I will mention them during the presentation. I will as well mention a little bit on the governance, but it will be just one slide, so don't be afraid. There's not a big talk about the governance on the European Innovation Partnership. We're well aware that European society is aging. But if you look at the predictions, then if you could give the figures to this, then it gets even more important how the situation is going to be in the next few decades. In 50 years...
Excuse me, could I just ask you to stay
closer?
To the mic?
Okay. Is it better? Thank you. In 50 years, the proportion of the 65 plus will almost double. But what is even more important and more striking is the proportion of the 80 plus. And it will be almost 200% higher than it is today. And this is very, very important in terms of the abuse as well, because these are the older people who are who are suffering more and more diseases and more seriously, and I will mention this in a few minutes. As well, this has important consequences on public finance, and currently the health spending in Europe is on the average roughly about 10%, and we expect, according to the studies which are available, to increase this, the proportion of spending on due to aging to be 5% of gross domestic product by 2060. Most probably we will face insufficient number of specialists to deal with the older population, with the increased number of older people in society. So there is a question of the shrinking workforce because there will be less younger people to work, but as well less specialists to deal with the elderly. And there is lots of innovation going on, and this is why we think the partnership could help to a little bit bring innovation and new ways how to deal with the issue to the ground and help them to be implemented sooner and maybe even better. Just to give a little bit more background on the medical implications of aging. Very important is the incidence of falls and fractures. And as you can see, 1/3 of people 65 plus do fall at least once per year. So this is very important. And the consequences are very severe, very often leading to death. Loss of physical functions, musculoskeletal diseases are very prevalent, as well as sarcopenia, the problem of losing the muscle force. Neurological degeneration, of course, Alzheimer, but it's not only Alzheimer, there are other diseases. What is as well very important and needs to be borne in mind is that most of the people will face some kind of multiple conditions, and this has a huge impact on care, including the social care, obviously. The European Innovation Partnership on Active and Healthy Aging is part of the overall European strategy, which is the Europe 2020 strategy. And one so-called flagship initiatives of Europe 2020 is the Innovation Union. And the Innovation Partnership on Active and Healthy Aging is the first pilot of the Innovation Union initiative. So in the communication on Innovation Union, it has been said that the Commission will try to pilot the partnership kind of approach, and the pilot will be on active and healthy aging. So it as well kind of shows the importance the Commission is giving to the issue. It needs to be said, it's not a new funding instrument, and it's not a new policy instrument in a strict legislative legal meaning. It aims to create a common vision around the issue, and aims to get the expertise together, and aims to generate better awareness and put together the resources in order to tackle the issue across Europe. The headline target of the partnership is to add 2 healthy life years by 2020, so in less than 10 years. I think this is quite an interesting picture, again, to kind of document the situation, which contrasts the life expectancy and the healthy life expectancy. And you see there's significant difference. And the difference is even higher for women, which is, again, very, very important. Apart from the headline target of adding 2 healthy life years on the average, the partnership tries to focus on so-called triple win, what we have called triple win for Europe. It's to allow the older people to live healthy, active, and more independent lives in the older age, to improve the sustainability of the social and care systems, because this will be crucial, and as well to actually help the businesses, to help them to innovate and to put them on the forefront in the global meaning. So to help them to develop new services, new products, new devices, which then could be, of course, marketed and sold globally, because aging is obviously not only a question of Europe, it's a global issue. So we hope that innovation could help to push the healthy life year expectancy, and this is just to chart it a bit, and to give you a taste of the main 3 areas which have been developed in the partnership so far, which is prevention, care and cure, and active and independent living, mostly focusing on the environment. Where we expect the added value of the partnership, apart for creating the joint vision, we hope that the partnership could help in joining up the expertise and the resources, as well could help in bridging gaps in innovation. So these gaps which are there, and I will show on one of the next slides, there are multiple gaps, wide new ways, including the social innovation, which might be one of the very important for the question of abuse, do not actually translate into action on the ground in terms of the policies and in the action of the actors on the ground. And as well, looking at how to potentially improve framework conditions. So this might be about legislation. It might be a lot about standardization. It might be a lot about guidelines and the ways how the things are being done. And the partnership helps as well to identify the activities or the actions which have proven to work and to scale them up to facilitate the faster scale up and multiplying in Europe. One of the important things, and I will get to this as well in one of the next slides, is the so-called users' involvement. We probably will need to find a better name for that, but this is about putting the older person in the center of all the activities. And this slide as well helps you a little bit to picture how we hope the partnership should join up actually the expertise from different spheres, including the industry, including the carers, including research and science, including the payers, which is a very important part, and the public purse part of the story. The partnership says that the innovation is not a linear process. It's kind of a process which is being repeated in different stages, and only if we manage to put in the center the users in all these stages, then we usually are successful at the end. So it's just to show that we're not thinking about very basic research and off we go, and we have a solution on the ground. It doesn't work that, and we have lots of results of research, but very little of implementation. We did our homework, and I led that group actually. We did our homework of trying to identify where our potential sources of funding just at the EU level. This is just EU. It's not including the member states or even regional levels. To see where some potential funding could be used for aging, active aging, independent aging, healthy aging. And you see the picture, which is quite complicated. There are a number of potential sources of funding. What we have found out, there seems to be very little funding on so-called demand side. What we see DG Sanko a little bit helps to do, which is my DG, with the public health program, and I think it has been actually the program which helped to finance one of the studies we just have talked about. To have funding for those who actually will implement the change, be it at the different scales, but that kind of demand side funding, and that as well connects to funding at the for public procurement and improving ways of public procurement of different services. We have run a public consultation at the end of the last year, and these are the results. We have received quite a good number of responses. We received over 500 responses, but some of the responses were very extensive. For example, we received one UK response, which incorporated a number of responses from the NHS, from Department of Health, from NHS in Scotland. A number of entities contributed to that response. So it has been extensive consultation, and we were looking mostly into three topics. First, what are the innovation barriers? Why new ways do not translate into practice? What are the existing and what are the future activities in this area carried out by different entities? And these are some of the results of the consultation. There's clearly problems with funding, but it's not so much about a lack of funding in general. It's more about the complexities, about the strings attached to various sources of funding. Also, people say there's a lack of evidence and data, and that again echoes the presentations I've been hearing this morning. There's not enough evidence on what works, how it works, why it works, what is cost efficient actually, because this is very important in order to prove to the decision maker in terms of using the resources. So the cost effectivity is one of the important issues. Some kind of regulatory framework conditions, but it's more about that there is a lack of interoperability of different solutions. So many solutions are being developed, but they are scattered and they do not communicate together. End-user involvement, I have mentioned that, and it's really one of the strongest issues which come out from the consultation, and I think it might be as well interesting result for you and to inform your future research, how to actually involve the older people in the design of various steps and design of various approaches. The healthcare systems, in terms of their stubbornness and stiffness, I would say, to change. And it's not about the healthcare system. I think it's a care system in general, and we should see more about the integration. I will mention this later on. With the social system, social care system. The existing and future initiatives are around different new ways of care. There's lots of research on independent living and assisted living technologies, and that's really interesting field. And here in the UK, the very important studies just being finalized. There is a whole system demonstrator which tries to test and prove how this assistive technology actually helped the older people. So-called continuum of care initiatives in terms to make care seamless when you need the hospitalization, so you would kind of like seamlessly get back to your house, which is the best for you. And there's clear evidence that the more you spend in the hospital, the worse for you, basically. There's as well lots of research and activities on actually generating new evidence. So there's lots going on in terms of so-called HTA, which is the health technology assessment. So how the health technologies actually, being it medical devices, being it pharmaceuticals, being it different technologies, are assessed. There's been a clear call for better exchange of ideas and better exchange of what goes on across continent, and we found out that lots of people do different things in different languages and different settings. It's not that easy for them to communicate, and the partnership would really like to contribute to this. We've been witnessing the change. The change has started and probably will accelerate. And again, the partnership would like to contribute to this acceleration. There's clear strengthening of the primary care and prevention, and we will need less focus on so-called acute care, and we will need more focus on prevention. There starts to be clear move towards kind of multidimensional approaches. Again, kind of stepping back from that very specialized acute care. One specialization just takes care of that one problem, but does not communicate with the other specialists, with the other physicians. And this is crucial that this does happen actually, because of the multiple conditions the older people do suffer from. The technology will enable people to self-care better, and there will be more moves, and then they're already happening, that the people will be able to stay longer in their homes, and will be able to manage the conditions they are at. Again, about the evidence, making the evidence better and robust is already going on, but we would need much more of that, and on much larger scale, actually. The partnership has been set up along all these entities which were mentioned on that one of the previous slides, and I will give you more detail on that later on. And there's been developed, there we set up a steering group. So the partnership, the Commission sees the partnership as a real cooperation of the different stakeholders, and the partnership serves as a secretariat in terms of the help the process to keep it going, to make it up and keep it going. The steering group members are appointed on kind of highest political level you can imagine, at the level of the ministers from the member states, at the level of the CEOs of the large companies, at the level of CEOs of the regions, for example. And in the steering group, together with so-called Sherpa group, which are people who are helping us and who are more able and more often to come to Brussels, because most of the meeting actually take place in Brussels to work. So far has set up kind of 3 priority areas. I have mentioned them already. One on prevention and diagnosis, and as well actually on awareness and on adherence to treatment, which is a very big issue. Second, on care and cure and kind of continuum of care, and the third on the environment and active and independent living. There is as well something which we have called the horizontal working group, or horizontal issues working group, dealing with funding, but dealing as well with indicators. And I'm leading that work. So if you're interested in indicators, I'm happy to discuss that later on. The first area on prevention tries to look into the things, as I have mentioned, on awareness, health literacy, on adherence, on disease prevention in general. The group on care and cure tries to address the issue of the continuum of care, which we see as a crucial, and of the integrated care, as well as trying to address the issue of evidence in terms of the available new technologies and the new approaches. The third group mostly focuses on information and communication technologies and other types of the devices which could allow people to live independently, basically. As well, there is an important issue which I have not mentioned, which is actually allowing people to stay longer in their workplace. And then there's a crucial issue as in terms of aging society. Getting just a little bit to the question of elder abuse. There's been a council conclusions from 2009, and the member states of the European Union called on the European Commission to do these 3 things, to run kind of review of ongoing activities on aging, to support future actions on dignified aging, and to develop awareness raising in terms of considering the year 2012 to be the year of active aging. As you see, the last has happened, the second has been happening quite a lot as well, especially with the support of DG Employment. And the third or the first, as you wish, is the one we are trying to contribute to, obviously. We are trying to help to kind of set the review of what goes on across the European Union. We are thinking with George, we're kind of like the most important connecting points with the elder abuse. Clearly, the integrated care issue. I think this will come to the fore quite importantly, because it's important in terms of both of the abuse in the domestic environment as well in the institutional environment. Social innovation needs to be mentioned. I kind of alluded to it. We understand innovation in very broad sense. It's not only about technology, but it's about a lot will need to be about changing the patient's pathways and the care models and the business models which actually support the care models. As well, it will need to be a lot about awareness and education and new base actually of awareness and education. So social innovation is very important as well. Information and communication technology has been mentioned, and I think there's a great opportunity if we develop these things right, if we develop them with old people from the very outset, that they can really help to independence and they can help to prevent, for example, the financial abuse. Training and in general helping to develop the skill sets and general human resource development around especially care. And as well, there's not enough evidence, and I keep mentioning it, but I like to mention it in this context again. I'm getting too close. I hope I'm on time. This is how the steering group's been set up. So it's co-chaired by 2 commissioners. So you see, it's very high on the political agenda. They are the highest people in terms of the European Commission in the structure. Then there are different member states present at the level of the ministers. There are a number of academics. There are older people organizations. There are patients. There are carers. Carers UK are on the steering group. There's H, obviously. H Europe is involved. Industry, but not only pharmaceuticals or ICT, but as well food industry, because function of food will be coming and will be much more important in helping older people to age actively. Out of the box thinkers we have as well. We have as well finance people and people from the associations of the insurers, social insurers. What are the next steps? Now the 3 working groups has been set up. They are just working right now, as I said. We will try to put the input from the working groups together in so-called strategic implementation plan. And it should be the document which should help to guide the whole process. The strategic implementation plan should be ready later this year, sometimes in the autumn of this year. And then we hope to develop a Commission's document, which is so-called communication, which will need to be taken on account by the member states, and we hope this will happen sometimes early next year. That's what I was about to say. Thank you very much. As I said, I'm happy to answer the questions, obviously.
You said about funding to implement the change. Who is going to be implementing the change and who's going to be regulating that?
It's very, very general, very broad question. I don't think there would be... Who needs to implement the change are all the stakeholders in all the chain, actually. And if we talk, for example, about the integrated care, we will need to see that the change does happen in the social department, in the health department. Lots of change will need to take place at the regional level in Europe. That's very important. It was on the slide, I forgot to mention. Regions are obviously represented on the steering group as well, because often health and social care is devoted, so it's governed at the level of the regions. So I think we will see lots of happening at the level of regions as well, potentially municipalities, because certain services are obviously provided by municipalities. Who will control them? Control them today, basically. The mostly national governments, because health is not a domain which is governed by the EU. We can help in research. We can help to put people together. We can do these things, but we cannot prescribe. This is the domain which is governed by the individual member states. So it will be their regulatory frameworks which will actually regulate how the change takes place. I don't know if it answers the question. Kind of.
So I think, those of us who are interested specifically in elder abuse need to figure out how to package the kinds of questions that we have, the service needs that we have within the context of the European project. And that's why I thought it was really important that we hear about it. So that, and again, we will make the presentation available to you so that you can study it. Because, you know, if we're going to move forward, we have to understand what are the issues du jour amongst those who are the policymakers. And, you know, we have to be smarter than we have been before. And I was very struck that on your very first slide, or very early slide, where you presented the statistics on falls. And I think those of us in our business need to think about how many of those falls are a result of abuse or neglect. And so, again, if you start to position the issues within the context of the broader picture, I think we'll have an opportunity to see some of the funds and the interest and the political will move towards this field.
If I can add to that. I think that there are number of kind of like touching points, and one of them might be developing of the guidelines. How do you actually prevent abuse, and to work with these guidelines in terms of this change which will happen, in terms of the continuum of change, in terms of assisted living technologies. So I think there's a lot which can be done, and obviously falls are very important, and falls are addressed from different angles, and this one more angle I think which deserves lots of attention, which has not been there yet, I think. There are other areas I think where the research could come to the fore, obviously, and we would be happy to hear the results of the research, and I think the best way is to communicate this to those who actually are on the steering group, and you can follow what goes on in the partnership. Obviously on the website we try to be transparent as much as possible, and you can contact them. You know, there will be someone probably either be it in the geriatrics field or gerontology field, or be it from the carers, for example.
Yes, I would like to make some push on Gloria's idea. My name is Marie Beaulieu. I'm from the University of Sherbrooke in Quebec, Canada. Actually, you were presenting kind of two frameworks at the beginning: healthy aging and also active aging. And for me, those two frameworks are quite different. But if we look at the active aging framework, it has been used especially in the program Age-Friendly Cities. And we see there that we have three pillars. We have health, social participation, and security. And I think that on the security point of view, we can do a lot in link with elder abuse. So that could be a way to push forward our ideas.
Just to react to that briefly, we try to put the things together in this partnership, and it's one of the kind of roles we would like to play as well. It's, as I had mentioned, just kind of a buzzword, kind of like trying to overcome the silo structure, or the silo culture, better to say. So you'd like to see healthy and active aging together, because there's clear evidence that the more active, the better for the health, obviously. So we try to picture this together in this framework. The notions you have mentioned, those health, social interaction, and security are clear ingredients of all this picture. And in terms, for example, of new technologies and how older people use them, we have clear evidence from trials among the older people that security is very on the upfront of the use. They use the security features of most of the technologies as the first ones, basically.
All right. Angie, did you have an announcement?
Are we going to break now?
Yes.
Just before, I think we're going to break now, but just to remind you, if you haven't taken the information which is around the room, it's an international collection of information from various participating organisations. So do help yourself over lunch towards the end.
Yeah, and in particular, you will find that there are copies of the new WHO report. Ariella, did you want to say a minute something about that since you were involved?
Well, this is the report which is there in the room, and Bridget and some other people working in elder abuse, we were very active on working on this report. This was the initiative of WHO regional office in Rome, and I think the EU, I'm sure and I hope the WHO is partnering. So there is, it's the European report on preventing elder maltreatment. It was just presented, and Bridget was there in Budapest on a conference on safety in Europe. There is a whole project on safety, as you said. And I think there is really a very broad overview of what's happening in Europe and what needs to happen, not only in research, but also in intervention, prevention programs, etc. So I think we can learn from it how we should move forward in this area and what can be done. And I hope the EU will allocate funding also in this area, because at one time, and I think it was DG Employment a few years back, we were an expert group working with them on the issue of elder abuse, and there was a big conference in Brussels on the topic. But then afterwards, not too much had been moved forward, from my point of view, from the EU perspective. So I am very glad that you have been here, Mark, and thank you for coming on such short notice. And I hope now something will move forward. So any one of you with any ideas, look also at the report, but what's happening, and I hope there are opportunities now to move further ahead. Thank you.